So now I will invite Dr. Fred Saad to come speak to us, but I will present him to you first, and he will begin the conference. So,
National Cancer Institute of Canada, Dr. Fred Saad is full professor and chief of urology and director of urologic oncology group at the University of Montreal Hospital Centre. That's the CHUM. He holds the University of Montreal Endowed Chair in Prostate Cancer Research and is director of the Molecular Oncology Research Lab in prostate cancer. Dr. Saad has been involved in most of the important clinical trials in advanced prostate cancer over the last 20 years and presently sits on 7 steering committees of international clinical trials and editorial boards, including Lancet Oncology, JAMA Oncology, Nature Urology, Urology, as well as Current Oncology. He has published 350 peer-reviewed articles with over 32,000 citations, as well as over 1,000 scientific abstracts, 8 books, and over 50 book chapters. As a matter of fact, one of his books is up front when you walked in. Dr. Saad's research interests include molecular prognostic markers, mechanism of progression, and new therapeutics in prostate cancer. He has over 40 clinical and basic research projects ongoing and has received over $30 million in research grants to date. In 2014, he received a Lifetime Achievement Award for research from the CHUM Research Center. Please welcome Dr. Fred Saad.
Thank you very much for the invitation, and it's always a pleasure to talk to patients and their families about prostate cancer. It takes up most of my time. My wife thinks I spend more time talking and working on prostate cancer than taking care of her, so that's a whole other issue for another evening. So let me start by saying that I'm going to present in English. That's what I was asked to do. The slides are going to be in French for people that are maybe a little bit more comfortable in French. This is something that Dr. Valiquette, my colleague, started when he was president of our association, out of respect that we have 2 distinct societies in Quebec, that when we speak in English, our slides are in French, and when we speak in French, our slides are English. And I think this is the tradition in our association. So for those that are English speaking, I think the terms are going to be relatively simple to follow. So I think before we start talking about prostate cancer, I like to just talk about what the prostate is, because a lot of times we're not really sure what it's useful for and what it does. So the prostate is really a gland that sits just below the bladder. So you see the bladder, the big balloon there, and the prostate is just sitting below right here. And the urine goes through the prostate and causes, obviously the prostate as it grows with age can block and can cause problems in urinating. And oftentimes people are worried when they have problems urinating, thinking, oh, this might be cancer and I have to consult. And it is one way of getting them to consult and be checked for their prostate to make sure they don't have cancer. But most of the time, it really has nothing to do with cancer. And even in the presence of cancer, when patients have symptoms, it's often due to the benign growth of the prostate with age. So this is something that's going to happen as we age. And the only people that don't develop a enlarged prostate with age are people that you castrate before puberty. And this was, in some countries, was something that was routine. And unfortunately, or fortunately, is not something that we do in North America. So men that are going to age with their testicles in place are going to have enlargements of their prostate and with age have problems urinating. So what is it useful for? It accompanies the sperm that comes from the testicles to be able to fertilize the egg and to have children. But after you stop wanting to have children, really the prostate is a useless organ. It's nothing but a bothersome organ that grows, causes symptoms, sometimes develops into prostate cancer and gives us a lot of work. So really, after the age of 40 or 50, when you don't want to have children anymore, it really only pays Dr. Valiquette's and myself's expenses. I mean, it is a source of income for urologists and really has no other use. It doesn't have any sexual function, except for producing the ejaculation Really, it has no function at all. It is not responsible for your orgasm. So the orgasm, you can have a very good orgasm even without a prostate. It is not responsible for the fertilization, because you can go from the testicle straight to the egg and still fertilize. So really, it is the reason, and Dr. Valiquette is going to talk about sexual dysfunction when we treat the prostate, but it's not really because of the prostate, and Dr. Valiquette is going to cover that. So as you heard, prostate cancer is by far the most common cancer that we diagnose in Canada, with about 24,000 men diagnosed per year. We still have about 4,000 deaths per year, unfortunately, from prostate cancer. It's the second or third leading cause of death in men in Canada. We are very proud to say that death from prostate cancer is declining over the last 10, 15 years, which is a good thing, I think, because we have better treatments. We're able to screen patients. We're able to diagnose earlier. The rates of prostate cancer death is consistently going down in countries that have been proactive in screening and have opportunities to get access to new therapies. In countries where they don't have the luxury of screening and where patients are living longer and longer, death from prostate cancer is actually rising. So in Mexico and other countries where people used to die very young because their healthcare system and their access to basic needs were not there, prostate cancer was a non-issue. As these countries now have better healthcare systems, people are living longer, healthier, prostate cancer is becoming a huge issue in Asia, in Africa, and in underdeveloped countries like Mexico. So what are the risk factors for prostate cancer? Really, the main risk factor is getting old. And the longer men live, the higher the chances that they will develop prostate cancer. It's almost a disease of age. And sometimes we will develop prostate cancer, but not any prostate cancer that's going to cause us problems. But even if we look at death from prostate cancer around the world, you realize that in countries that are in orange here, this is North America, Australia, Western Europe, those are the highest rates of death from prostate cancer around the world. And then you have countries that are in yellow where the lowest rates of death from prostate cancer in Asia. And we think that it's probably related to diet. We think it's probably related to environmental issues, because when you take somebody from Asia and they immigrate to North America, within 2 generations, they catch up to the rate in North America. So we don't think it's a genetic issue. And in Africa, prostate cancer death is intermediate. But as these countries are also living longer and longer, we're realizing that they have a very high death rate. Family history is the other main risk factor. So it's exactly the same as breast cancer. These are 2 cancers that really are almost identical. The more prostate cancer in the family, the higher the risk of you also being affected by prostate cancer. Same as breast cancer. And we also have similar genes that predispose us to breast cancer and prostate cancer. BRCA, that everybody talks about, is also present in prostate and increases the risk. So I was talking about race. The highest rate of prostate cancer in the world right now is in African American males. So if you are in the black race, for some reason that we still haven't fully figured out, they are at higher rates of prostate cancer. But we don't hear about it in Africa because there are other priorities, and prostate cancer is not a huge issue in Africa. But if you take African Americans or Africans that move to countries where they have long life expectancies like Guadeloupe or Martinique, where they live clearly into their 80s, well, their prostate cancer is by far the biggest killer in men. Diet, weight, those seem to be risk factors for prostate cancer, and also, as I mentioned, geography. And when you look at geography, you look at mortality by prostate cancer, and what you notice here is that countries with the least amount of sunlight have the highest rates of death from prostate cancer. So Switzerland, Norway, Luxembourg, Iceland, Canada. And there might be, we're still unsure of why the rates of prostate cancer and maybe the death from prostate cancer is higher in these countries. We think maybe it's a vitamin D issue of deficiencies in vitamin D. And you look at countries like Greece, Ecuador, Italy, with different diets, but also more sunlight, there seems to be less death from prostate cancer. So we're slowly learning more and more. We can't purely prevent it, but we might be able to make impacts if we know how to do a better job in understanding the environment, because genetics is part of it, but a big part of it is environment. So can we prevent prostate cancer? There's a lot out there about preventing all sorts of diseases, including cancer. And by far, prostate is one of the ones that you will hear the most about. It's $1 billion industry in the States. People are buying all sorts of things based on no literature at all or no evidence at all to try to prevent prostate cancer. It's really an industry in itself. There is a lot of publicity about what you can do. So much so that we thought vitamin E was protective against prostate cancer based on historical work that was done. So there was actually a study done by the NIH in Canada. $350 million was invested in a study to try to prove that vitamin E might help to prevent prostate cancer. So what was the result? It actually increased the risk. So it didn't only prevent it, it actually made it worse. So if there's only one message you take from here today, is be careful when you hear all sorts of things about how to prevent cancer. So vitamin E actually statistically significantly increased the risk of developing prostate cancer if you take high doses of vitamin E. And for us as surgeons, we don't like high doses of vitamin E. The patients bleed more, and there are also issues with cardiac problems taking too much vitamin E. So be careful. Sometimes you hear there's no danger with vitamins. Unfortunately, the reality is not true. There are dangers with vitamins. Selenium, if you take nuts, there's no way you're going to overdose on selenium. So if you take Brazilian nuts, that's a great source of selenium. But if you go out and buy supplements of selenium in pills with high doses, this was also part of that $350 million study. There was no reduction in prostate cancer. It was actually slowly increasing, not as bad as vitamin E, but actually increasing. But what it did increase is your risk of developing diabetes. So don't take selenium in high doses. In low doses, it seems to be a wonderful thing. And if you like Brazilian nuts, buy as much as you want. You won't overdose. Vitamin D, this might be the only safe vitamin that we know of that might actually be helpful. And it's not only limited to prostate. The Canadian Cancer Society actually recommends us to take supplements of vitamin D, mainly because we live in an environment with very little sunlight, and today is a perfect example of why we need vitamin D. It also helps for bone health, which also reduces your risks of living long if you develop osteoporosis and fractures. Soya, it's still a question mark. There might be some benefits to soy and might be part of the reason why Asians develop less prostate cancer, but we're not sure. And I wouldn't suggest that everybody here start taking huge amounts of soya, because we don't have the genetics to digest soya as a lot of Asians do. So it might actually be detrimental to start changing our diets tremendously. Tomatoes seem to have no harm. Do they protect? We don't know. The data is conflicting, but it doesn't seem to be harmful. So if you like tomatoes, it might actually be helpful, especially if they're cooked. And green tea, we hear a lot about green tea. Again, conflicting results. In Asia, it seems to be possibly helpful when they do studies, but again, the way they digest the green tea might be different. So bottom line, what do you do if you want to help yourself to reduce your risk of either developing prostate cancer, or if you have prostate cancer, reduce your calorie intake. We think that it might not be so much what you eat, but how much you eat that makes a difference. So try to be reasonable in your calorie intake. If you're going to reduce something, reduce your carbohydrates. Definitely, if you can increase the amount of exercise you do, and we're actually doing a study now, international study, to try to prove that actually exercise prolongs life in men with metastatic disease. So at the end of the stages of prostate cancer, we want to prove that exercise can actually prolong life. We already know it improves quality of life, but we want to look at it as if it was a drug that you're giving to prolong life in prostate cancer. Fruits and vegetables seem to be protective and helpful. Eat meat in moderation. Don't stop eating meat, but in moderation. Maintain a healthy weight. And for now, the ideal diet is really unknown, but what is consistently coming and coming up as being proof is that if it's good for your heart, surprisingly, everything good for your heart seems to be good for your prostate. So think about your heart first, because as much as we're obsessed with prostate cancer, every man in this room has a much higher risk of actually dying of their heart than of their prostate cancer. And so you have to think of your heart first, because yes, cancer is killing more men and more women than heart disease, but it's all the cancers combined. No single cancer comes anywhere close to how many people die of heart disease. So keep thinking of your heart and try to work both on your heart and your cancer. So how do we diagnose prostate cancer, and should we be screening? So here, these are the studies that were done that you might have heard about. There was a study done in Europe that showed that if we screen for prostate cancer, we reduce the risk of dying of prostate cancer. So this was the first real evidence. It took 150,000 men randomized to screening versus the standard of care. If symptoms develop or whatever, that you would be tested for prostate cancer, but not actively screened. And it showed about a 25% reduction in dying of prostate cancer. The problem was that you had to screen about 1,400 men, treat about 48 men to save one life. So the cost of screening everybody and not thinking about what we're doing is probably too high a price to say that we should be screening blindly for prostate cancer. The problem was that at the same time that study was done, an American study was done that showed that screening made no difference in the States. That there was no difference in dying of prostate cancer whether you were screened or not. But the problem in the States is that anybody who wants to get a PSA test can just go across the street and get it done. So it's very hard to really see if screening was adding anything to what people are doing on a daily basis. And actually, the people that were not supposed to be screened in the American study were actually more screened than in the screening study of the Europeans. So in terms of access to PSA, it's a problem of contamination. So this study really didn't help us. It only just added to the confusion. The only study that I think was really well done was a study done out of Sweden, where these patients were screened or not screened, and you didn't have access to PSA if you were not in this study. And what this study showed is that you actually reduced the risk of dying of prostate cancer by over 40% when you're screened. And so this was the most convincing data when you do a study properly that screening can be useful to reduce the risk of dying of the disease. So what do we have as a challenge is when we diagnose somebody with prostate cancer and we do a biopsy and we look under the microscope, we have patients that look the same under the microscope. On one side, we have a patient who was treated and cured and the cancer never came back. And the other side, the patient died of prostate cancer. So there's something more subtle to just making a diagnosis of prostate cancer that we still need to be working on. And this is where the biobank of Procure is trying to help us to better understand what is actually going on that makes this difference occur. So if I summarize the screening issues, prostate cancer is important. There are a lot of patients that don't actually need to be treated that are being treated. And there are some that are actually being treated, but not treated aggressively enough because their cancers are too aggressive based on what we diagnose. So the whole attention should be not only around screening or not, but on trying to understand who we actually need to treat, who we can observe without treating at all and avoid the complications that Dr. Valiquette is going to talk about, and how best to treat the individual patient. And this is really where the whole field of cancer is going, in a personalized approach to treating prostate cancer and every cancer that we treat. And this is only going to come through investments in research, because we all know that we're all different in this room, and even within one cancer, there are a lot of differences between the same cancer. So I'll go relatively quickly. A lot of people probably know how we diagnose prostate cancer. The rectal exam is still part of the diagnosis of prostate cancer. So as much as men would like to say, I don't need to do a rectal exam anymore because I did a blood test, it's not true. There are cancers that we diagnose when we examine a patient that unfortunately we miss with the PSA. Obviously the PSA helps a lot, but it's important to do the rectal exam because it helps us one, sometimes to diagnose a cancer we might have missed with the PSA, but also it gives us an idea of how extensive the cancer is when we examine the prostate. PSA is the blood test. It's a protein that's produced by the prostate. It's not anything dangerous. So some people wonder, my PSA is high, is it harmful to my body? It's not harmful. It doesn't do anything itself. It's just a reflection of the risk of having prostate cancer. And the higher the PSA, the higher the risk of cancer. And if the PSA is really high, there's a higher risk of the cancer being spread. So the PSA helps us to gauge to what extent the cancer is aggressive. Ultimately, the only way we make a diagnosis of prostate cancer is through a biopsy. So we're hearing a lot about different tests, but you still need to do a biopsy, take a needle and go into the prostate and examine it under the microscope. We're hearing a lot about MRI. So an MRI allows us to visualize the prostate, but doesn't replace the biopsy. Sometimes it will help us to identify where the cancer is, because sometimes we do a biopsy, and what you have here is the rectum. So sometimes we do a biopsy and we miss the cancer because it's too high up. And so in some cases, the MRI can be useful. It's still not something we do routinely in every patient. There are tests that we're developing where the cancer actually lights up to help us know where it is, and maybe will eventually will help us to follow a patient who has a diagnosis of cancer, and maybe eventually even replace the biopsy, but we're not there yet. The Gleason Score is what we hear about. We hear a grade when you get a diagnosis of cancer, whether it's grade 1, 2, 3, 4, or 5. And this is, more recently, we changed the way the grading is so that until a Gleason Score, a grade of 3, the cancer is really not aggressive. And at 3, it only starts being called cancer. And we think that the 3 has very little risk of actually spreading or causing harm. And that's why these Gleason 3s, sometimes the doctor will tell you, we don't need to treat the cancer right away, we can watch it. Because we realize that these cancers, with this new classification, are really at low risk of causing problems. As soon as it becomes Gleason 4 or 5 on the biopsy, the risk of the cancer escaping out of the prostate goes up, and these patients, most of them, will require treatment. What we've done more recently is try to group, because sometimes because the Gleason grade, 3, 4, or 5, is added if there are 2 types of grades, and it gives you a Gleason 6 if it's all Gleason 3 plus 3. But when you tell somebody you've got a Gleason score of 6 out of 10, and don't worry about it, some patients look at you and say, 6 out of 10 sounds pretty bad to me. So we're starting to change the way we give the diagnosis, and now we say it's group 1. And group 1 has a very low risk of causing harm to the patient, has an excellent prognosis, and really is probably a cancer for most men, if it's small, doesn't require treatment. Once it becomes group 2, that's 3 plus 4, so it's starting to be a little bit aggressive. These patients have very good prognosis, but probably do need to be treated if they're healthy and relatively young. And then the grades go up. So it goes from 1 to 5, maybe a little bit easier to digest when you talk about it. And when you look at what happens when you're diagnosed with a group 1, you see almost nobody's gonna develop progression, develop metastases, and especially die of prostate cancer. The risk of dying of a group 1 cancer is 1% at 10 years. There was just a recent publication where patients with this kind of cancer followed for over 10 years, the risk of actually dying of the disease, even if you weren't treated, was 1%. And so that's how we're starting to help patients to decide what to do. In terms of the grades, that's the Gleason. Now we have the stages. So how extensive is the cancer when we do a rectal exam? So the T1 is when it's very small, we don't feel anything. T2 is when it's starting to feel hard, there's a nodule, but hasn't gone out of the prostate. And then 3 and 4 is when it's starting to come out of the prostate, and eventually some men will develop metastases where it goes into the bone. And this is the bone scan that helps us to determine whether or not it touches the bones. So we put patients into risks. And if you have a diagnosis of prostate cancer and the PSA is below 10, and your Gleason score is at most 6, and on the rectal exam we don't feel anything or just maybe a very small nodule, those patients are at low risk, and many of these patients we don't need to treat, at least not at the start. On the other extreme is a high-risk patient. So a patient with a PSA above 20, a Gleason score of 8 to 10, or if we think that the prostate or the cancer has escaped outside of the envelope of the prostate, those patients all need to be treated, and we're going to treat them aggressively, because if we don't, the risk of actually being harmed by the prostate cancer is high. But even these patients with the worst prostate cancers, we can expect that they were going to live clearly beyond 10 years, and many of these patients live beyond 20 years with everything we can do now. So how do we treat? Well, we're going to treat based on the grade and the stage of the disease, but we also put a lot of importance on the age of the patient and their general health, because how long they have to live, everybody in this room is going to die, right? We agree on that? Okay. What we don't know is when. And so life is a competition, right? We're all going to die of something. My role is that you don't die of prostate cancer. And so if somebody is not very healthy, we discuss, and they look like they might not live beyond 10 years because of their heart or whatever, sometimes we'll be less aggressive with a cancer that we believe will take more than 10 years to cause problems. Okay, so sometimes it sounds a little bit harsh, but we need to take care of quality of life, because Dr. Valiketa is going to talk to you about quality of life, and this is very important. So if somebody only talks to you about treatment and doesn't take anything else into consideration, it's not the right thing to do. So, and the patient choice is going to be very important in how they view their cancer. If it's a very localized disease, we can offer active surveillance, surgery, or radiation plus or minus hormones, depending on how aggressive the disease looked in the prostate. If, unfortunately, patients came in with cancer already spread, well, then we have to treat. And in that case, it's going to be hormone therapy, and I'll talk about that in a minute. And now we're starting to use even chemotherapy at first diagnosis in somebody who comes in with aggressive disease. So how do we treat? I'll be very brief, because I'm sure these are all things that you're discussed and we can talk about it in the question period. But a lot of people hear about brachytherapy. This is implants of little radioactive seeds that go into the prostate and will try to kill off the cancer. This is only good for patients who have low-risk disease. Remember that category? Not very aggressive disease, because these radioactive seeds only send radiation just around their seed. And so they won't be able to go outside of the prostate if the cancer is more aggressive. So these we do it's a day surgery. The radiation therapy does it. They put in a little probe in the rectum to see the prostate. You're under spinal anesthesia, and we put these seeds in. This is not for everybody. This is really for the low-risk disease. Radiation therapy externally is for all kinds of patients, and how much radiation we give, whether or not we give hormones, depends on how aggressive the disease is. And the risks of radiation have gone down a lot, but they still occur. And the amount of radiation we're able to give today is much higher than what we were able to give before. And so the results are much better than what they used to be. And in our institution and others, we have a cyber knife. In some cases, it might be relevant. And this is almost like a missile that as the prostate moves, it can aim at the prostate. We use it more for brain cancers, because it's extremely important that any movement is detected by the radiation therapy machine, not to leave more scarring than necessary. When we operate a patient, the goal of operation is to take out the whole prostate, because the cancer is never limited to just one small area. So we have to take out the prostate and the seminal vesicles, so they're in yellow. And we do this in 3 steps. We have to cut the urethra, so where the urine is passing. And then we have to cut the bladder, so that we can take the prostate that's connecting the bladder to the urethra. And in cases where the cancer is not too aggressive, sometimes we can save the nerves on either side of the prostate, and Dr. Valiquette is going to talk about what happens when the nerves are cut because the cancer is too aggressive or because it was unable to be saved. And then we're going to reconnect the bladder with the urethra after we take the prostate out. So sometimes you hear about surgery through the penis. That's really only to relieve symptoms. It doesn't treat prostate cancer. So it's not because the surgeon is not good. It's because for prostate cancer, we have to take the whole prostate out. We can't just take out part of the prostate. And this can be done with an open surgery with a small incision below the umbilicus, or through laparoscopy or robotics with 5 little incisions using cameras to work. The operation remains identical either way, and it really depends more on the experience of the surgeon than the technique that's used to determine how well the cancer is going to be cured, whether you're going to have problems with your urine or problems with your erections. So this is what a robot looks like. I won't show you all the details, but the robot, the advantage is that it has more movement and resembles more the hand that you want to be able to reproduce. And this is what it would look like in the operating room when you have a robotic surgery. So you see the big instrument that's on the patient, the assistant is sitting there, and this is the surgeon right here. So the surgeon could be in New York and you could be doing a surgery in Paris. It doesn't really matter where they are, and as long as the assistant is doing a good job here. So the surgeon is never very close to the patient when you're doing robotics. It's obviously important he be in the room if there's a disaster that happens, but most of the time it can be done elsewhere. So what happens if we don't treat prostate cancer? Well, here, this is one of the few cancers where we actually have patients that didn't get treatment, and we know what happens over 15, 20 years. And what it's important is that depending on your age and how aggressive the Gleason score is, you can predict the chances of dying of prostate cancer compared to the chances of dying of something else. Because like we said a few minutes ago, we're all going to end up dying. So in light gray is the chances of dying of any cause. And you see that if a Gleason score is below 6, the chances of dying of anything is much higher than the chances of dying of prostate cancer. But once you get to 7, 8, and 10, the chances of actually dying of prostate cancer, regardless of your age, is quite high. This is relatively old data. This is already 10, 15 years old. This is before we had a lot of these new therapies we have today. So the risks of dying of prostate cancer have reduced tremendously over the last few years. So what happens after you're treated? Surgery, radiation. We look at the PSA, because even if you don't have a prostate, if the cancer comes back anywhere in the body, it will produce PSA. Because patients ask, why are we checking the PSA if I don't have a prostate? It's because if cancer comes back in the lymph nodes, comes back around where the prostate used to be, comes back in the bones, the PSA will go up. And it's often not a disaster if the PSA goes up. This is not a death certificate. PSA goes up, there are lots of things we can do to help recover. So we look at first, has it spread? Can we see anything on the x-rays? How long since the treatment? And what was the treatment we gave? And how fast is the PSA going up? These are all important in deciding what to do, because we don't need to treat every patient that has a PSA going up. And sometimes we're better just to watch it and monitor it before we give any treatment. Every treatment has some side effects. And the options, if the PSA goes up, if you are operated, you can get radiation therapy. If you had radiation therapy, you can get hormone therapy. And hormone therapy was the only Nobel Prize that was won in urology. This was about 70 years ago that it was discovered that prostate cancer can be controlled with hormone therapy, and hormone therapy is reducing testosterone to its lowest level. And you've probably seen these different hormones if you're on hormone therapy. These are all injections that we give every month, 2 months, 3 months, 6 months. There are all sorts of injections, and these are pills that we can give with the injections in some cases. But the whole idea is to do the same thing as if we took off the testicles that produce testosterone, and that makes the cancer shrink because it's fed by testosterone. Unfortunately, there are side effects to hormone therapy. You can have a loss of libido because the testosterone is what controls your libido. You can be more fatigued. You can also develop some problems with your bones because as you lower testosterone, the risk of osteoporosis goes up. But these side effects are very tolerable in patients who need the hormone therapy. What we've done to try to reduce the risks is to give the hormone therapy in bursts. So we give hormone therapy for about 6 months. We can take a break, let people recover, and when the PSA goes up again, we can start over. And that reduces the amount of side effects in patients. So I'll end on just a few, I think, important notes that sometimes people say, well, my cancer is already spread. I don't have much time to live. That reality has changed a lot since I was a resident under Dr. Valiquette. He looks young, but he actually trained me. But for some reason, he ages much better than I do. But at the time I was training with this old man here, we had nothing to offer patients when they were metastatic. We would do a surgical castration, or we would do hormone therapy, and that's it. And we would just cross our fingers and hope for the best. The patients would live maybe 2, 3, sometimes 5 years, some patients even 10 years with just hormone therapy. Nowadays, hormone therapy is still the base of the treatment for patients that come in with cancer that's spread outside of the prostate in their bones, liver, etc. What has changed is that sometimes we'll even give chemotherapy up front. And why we do that is that a recent study showed that giving chemotherapy when the cancer is spread tremendously increases the amount of time patients will live. And now we're talking about patients living over 5, 6 years with very aggressive disease, and we see patients now living even much longer than that. So when we give hormone therapy and things go well, they can go well for years. But at one point, the cancer develops resistance to hormone therapy. What that means is it finds a way of surviving even though there's no hormone to feed it. And that's when we really run into some problems. Fortunately, you see over the last 10 years or so, we have a lot of new treatments when we reach that stage. And these new treatments have actually doubled the amount of time patients live when they reach this stage of the disease of resistance to hormone therapy. And all of these therapies have a goal of not only prolonging life, but also improving quality of life. So one of the issues with prostate cancer is that it spreads to the bone, and it can cause pain, and it can cause even sometimes fractures, sometimes paralysis. And so there are 2 drugs that were developed that reduce the risk of these complications significantly. That's zoledronic acid and denosumab, or Zometa, and Xgeva, which is the more recent one that's being used. So it reduces the risks of complications, lowers pain, and helps maintain quality of life for longer. But it doesn't prolong life. The more recent treatments to help prolong life started with chemotherapy. So chemotherapy, both docetaxel, that's Taxotere or cabazitaxel or Jeftana, these names you might hear if you're at that stage of the disease, have been proven to prolong life, lower pain, and even though there are side effects to chemotherapy, improve quality of life. What came about more recently, and which was very exciting for many men who either didn't want chemotherapy or couldn't take chemotherapy because their health didn't allow them to, was abiraterone. So this is Zytiga. These are pills that are actually based on hormone therapy, but more powerful, and we add to the hormone therapy we use as a base. And this really acts to try to stop the cells from producing testosterone anywhere in the body. And again, prolongs life, reduces pain, and improves quality of life with very little side effects. And so this is what we use in the first line of patients before giving chemotherapy for most of the patients who have progressed to castration resistance. Enzalutamide is another hormonal therapy that was developed that has a different way of acting on the cells, but through the androgen receptor. And this again prolongs life, reduces pain, and improves quality of life. And the most recent one is radium-223, which is really a radioactive that we give intravenously. And it goes into the bones to try to kill off the cancer cells and the problems going on in the bones that cause these complications. And what this showed was that we were able to prolong life, reduce complications in the bones, lower pain, and improve quality of life. So you're seeing this recurring theme of drugs that none of them cure the cancer, but when we use them one after the other, we can help patients stay at home, maintain quality of life, and live longer. And so in 2011, this is what the patient would look like: get hormone therapy, progress, get chemotherapy, and unfortunately, we had nothing else to offer. This is what it looks like today. We can give things before chemotherapy, we can give things after chemotherapy, and we continue to give something to try to help control the bone metastases when they occur. And this is the kind of patient that we see today. A patient that historically would have lived about 18 months, who lived 6 years, getting different therapies through the continuum of their disease. Unfortunately, all of these patients, if they live long enough from other diseases, will succumb to their disease, but we keep them with the best quality of life possible and try to keep them alive and well as long as possible. So I'll end with some of the future is that we're starting now to take biopsies of patients to try to see if we can personalize drugs to their individual cancers, which is where the field is going. First example is a PARP inhibitor that we're using now in clinical trials that show that if you have a certain genetic profile, you have a much more chance of responding to this kind of therapy. And the future is probably going to be taking a blood test, trying to decide based on the cells that come from your prostate cancer what the best treatment is for you, rather than taking a biopsy, and try to tailor individual treatments to what the patient needs to be able to live as long and as well as possible. And in our lab, we're working, taking patients' samples, putting in combination with drugs to be able to figure out what is the best treatment for the individual patient. So I'll conclude by saying that screening, I truly believe, helps to save lives. Treatment for localized disease has improved a lot over the last few years. Treatment for metastatic disease has really seen some spectacular improvements over the last 10 years because of research, and that I think that patients and families can be optimistic for the present and for the future, since research is continuing, and through initiatives like Procure, we're able to better understand the disease and hopefully cure more and more men, regardless of the stage that they're diagnosed in. So thank you very much.